where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning and welcome to UroNurse. I'm your host, Vic Senese, back in the flesh. No pre-recorded on this one. I'm back from my cruise. Had a great time in case you're interested, but always kind of miss getting back in the studio and meeting with everybody online. So it's great to have everybody back. Hey, if you're just checking us out for the first time, don't forget to like and subscribe to the show. You guys are killing it on the subscriptions. We're up to over 6,000 subscribers. And 2.5 million. We just turned another 500,000 over. So it sounds like we're doing good. All right. So let's talk a little bit about what's going on here today. Urinary. Oh, wait a second. Before I do that, let me bring in my co-host here. So let me just, I always scoop that up. There we go. There we go. Lori, welcome to the show.
Good morning, everyone.
See, I got out of practice from being away.
Yeah, I know. You're slacking.
I'm telling you. But I'll get back into the groove. Don't worry. So how's everything going with you, Lori?
Oh, I'm doing great. I'm glad you had a good trip.
Yeah, it was a lot of fun. Glad to, like I said, glad to kind of be back in a way. It's nice to get away. But it's weird when you're working and you go on vacation, you get away from everything, the stress of the job and all that. I'm retired. I'm not getting away from anything, really. Not a lot of stress. I mean,
all
the worst thing I had to do was had to power wash the deck yesterday, so I got away from power washing for a while.
Oh, just rub it in, Vic.
It'll happen to you someday. So, all right. Well, today, so not that far. I went too far into the show. Man, I really am out of practice. All right. So, urinary tract infections remain one of the most common reasons patients seek medical care. Yet, diagnosis, treatment continue to evolve as we face increasing antibiotic resistance and new prevention strategies. In today's program, I'll review the latest evidence on recognizing UTIs, selecting appropriate therapies, avoiding overtreatment, and helping patients reduce their risk of future infections. So, hey, everybody, thanks for joining us, and let's get started. Today on UroNurse, I take a focused look at UTI updates for 2026. Diagnosis, treatment, and prevention explained, highlighting the latest evidence shaping clinical practice across urology, primary care, and long-term care settings. From evolving diagnostic strategies and the growing role of advanced urine testing to current recommendations in antibiotic stewardship and management of recurrent infections. This episode is designed to help keep healthcare professionals aligned with the most up-to-date guidance. Also, I'll review practical prevention strategies that can be applied in real-world clinical workflows to improve patient outcomes, reduce unnecessary antibiotic use, and support more accurate, timely decision-making at the bedside. In the management of urinary tract infections, healthcare professionals must move beyond the heuristic guessing, treating based on pattern recognition alone, and instead anchor decisions in objective antimicrobial stewardship principles. While clinical experience and symptom recognition remain important, reliance on assumption-driven treatment can lead to overdiagnosis, unnecessary antibiotic exposure, and increasing resistance, particularly in cases of asymptomatic bacteriuria or atypical presentations. Objective stewardship emphasizes evidence-based criteria, validating diagnostic testing, culture-directed therapy, and guideline concordant decision-making to ensure antibiotics are used only when truly indicated. By shifting from guesswork to structured clinical reasoning, clinicians can improve diagnostic accuracy, reduce collateral damage from inappropriate therapy, and support long-term preservation of antimicrobial effectiveness. In clinical practice, UTI treatment can be streamlined by applying two core principles: distinguishing localized lower urinary tract infections from systemic or complicated infections. Localized infections such as uncomplicated cystitis are typically confined to the bladder, presenting with dysuria, frequency, and urgency without systemic signs, and are generally managed with targeted, short-course oral antibiotics. guided by local resistant patterns and, when available, culture results. In contrast, systemic or complicated UTIs, including pyelonephritis, urosepsis, or infections in high-risk patients, require broader initial evaluation, blood and urine cultures, and often empiric broad-spectrum IV antibiotics, with escalation or de-escalation based on clinical response and susceptibilities. Applying this two-tiered framework helps clinicians avoid overtreatment of simple infections while ensuring timely, aggressive management of infections that pose risks for systemic illness and adverse outcomes. Now, the golden rule for asymptomatic bacteria is simple but critical. Do not treat it with antibiotics unless there is a specific, evidence-based exception in most patients, including older adults, those with diabetes, indwelling catheters, and long-term care residents. Bacteria in the urine without urinary symptoms represents colonization rather than infection and should not trigger antimicrobial therapy. The key exceptions where treatment is indicated include pregnancy and certain urologic procedures with anticipated mucosal bleeding, where reducing infectious risk is clinically necessary. Adhering to this principle is central to antimicrobial stewardship, as unnecessary treatment of asymptomatic bacteriuria contributes to resistance, adverse drug events, and disruption of the normal microbiota without improving patient outcomes. In patients with dementia, clinicians often face the mortality paradox, where the instinct to aggressively treat suspected urinary tract infections may inadvertently shift care towards avoidable harm rather than meaningful survival benefit. Overdiagnosis of asymptomatic bacteriuria or nonspecific symptoms such as confusion or functional decline can lead to unnecessary antibiotic exposure, hospital transfers, delirium, and complications like C. difficile infections, all of which may worsen overall outcomes and quality of life. Now, at the same time, true urosepsis is a real and time-sensitive emergency where delayed recognition and treatment can increase mortality. The clinical challenge is therefore careful differentiation, recognizing objective signs of systemic infection versus nonspecific behavioral or cognitive changes common in dementia, so that clinicians avoid both overtreatment and undertreatment. This balance is central to reducing preventable harm when ensuring rapid intervention when sepsis is genuinely present. In suspected UTIs presenting with delirium, especially in older adults, the verification first pathway prioritizes confirming true infection before initiating antibiotics. Rather than attributing acute confusion automatically to urinary infection, clinicians first assess for objective evidence of infection, including localized urinary symptoms, fever, hemodynamic instability, and supportive laboratory or culture data, while simultaneously evaluating alternative causes of delirium such as dehydration, medication effects, metabolic disturbances, or environmental triggers. Urinalysis and culture are interpreted cautiously, recognizing that bacteriuria is common in older and institutionalized populations and may be incidental. This structured approach reduces diagnostic anchoring, preventing unnecessary antimicrobial use, and ensures that antibiotics are reserved for cases where there is clear clinical correlation between symptoms and confirmed infection, thereby aligning delirium management with both patient safety and antimicrobial stewardship principles. Continuous remote monitoring, including multi-layer perceptron machine learning models, is increasingly being explored as a tool to support early detection of clinical deterioration in patients at risk for conditions such as complicated UTIs and urosepsis. These systems integrate continuously collected physiological and clinical data, such as vital sign trends, laboratory patterns, and nursing documentation, to identify subtle preclinical signatures of worsening infection and generate early alerts before overt symptoms emerge. When appropriately validated and integrated into clinical workflows, such models can enhance situational awareness, prompting earlier assessment, diagnostic confirmation, and timely escalation of care. However, their effectiveness depends on careful calibration to minimize false positives. avoidance of alert fatigue, and ongoing clinicians' oversight to ensure that algorithmic predictions are interpreted within the broader clinical context rather than replacing bedside judgment. Hey, I warned you this AI would be creeping into our practice. In UTI management, a key system-level tension is the speed of certainty, where legacy workflows often rely on urine culture confirmation that can take up to 48 to 72 hours, versus emerging rapid diagnostic platforms that can provide actionable microbial identification and resistance data in as little as 4 to 6 hours. While traditional culture-based methods remain the diagnostic gold standard, their delayed turnaround can perpetuate empiric broad-spectrum antibiotic use, potentially increasing resistance and prolonging inappropriate therapy. Rapid diagnostics, when integrated into stewardship pathways, allow earlier de-escalation or targeted therapy, improving clinical precision and reducing unnecessary exposure. The challenge for healthcare systems is not only adopting faster technologies, but also redesigning workflows so that rapid results are acted upon in real time, ensuring that faster certainty translates into better clinical decisions rather than simply faster data accumulation. Now, the European Association for Urology guidelines take a restrictive, stewardship-focused stance on fluoroquinolone use in urinary tract infections due to well-documented safety concerns and increasing resistant patterns. Fluoroquinolones are no longer recommended as first-line therapy for uncomplicated cystitis and are generally reserved for situations where alternative agents are unsuitable and susceptibility is confirmed, particularly in more complex infections such as pyelonephritis or complicated UTIs. The guidelines emphasize that their use should be guided by local resistant data, culture results, and careful risk-benefit assessments, given the potential for serious adverse effects including tendinopathy, QT prolongation, diglycemia, and rare but severe neurologic or aortic complications. Overall, the EAU framework prioritizes narrower spectrum agents whenever possible and reinforces fluoroquinolone stewardship as a critical component of preserving antimicrobial effectiveness. The PRISMA-aligned approach is a first-line therapy for uncomplicated urinary tract infections, emphasizing narrow-spectrum targeted agents such as nitrofurantoin, trimethoprim sulfa, and cephalexin, selected based on local antibiograms, patient-specific factors, and resistant patterns. Did you guys look at your antibiograms ahead of time? Nitrofurantoin is often preferred for uncomplicated cystitis due to its high urinary concentration and low collateral resistance, provided renal function is adequate, while trimethoprim sulfa remains appropriate when local E. coli resistant rates are acceptable and there are no contraindications. Cephalexin serves as an alternative option, particularly in patients with intolerance or contraindications to first-line agents, though it may be less optimal in some resistant settings. Across all choices, the PRISMA framework reinforces the importance of limiting treatment duration, avoiding unnecessary broad-spectrum antibiotics, and aligning prescribing practices with stewardship principles to preserve antimicrobial efficacy while maintaining high clinical cure rates. In systemic, complicated urinary tract infections, a structured, empiric pathway stratifies therapy based on risk of resistant organisms and clinical severity, beginning with broad IV coverage and early de-escalation once data are available. And in patients without specific risk factors for resistant gram-negative pathogens, empiric ceftriaxone 1 to 2 grams IV every 24 hours is often appropriate. However, in patients with higher risk features for Pseudomonas, anti-pseudomonal agents such as ceftizimid 2 grams IV every 8 to 12 hours are preferred. And where extended spectrum beta-lactamase producing organisms are a concern, carbapenem therapy such as ertapenem 1 gram IV every 24 hours is commonly utilized as initial coverage. Across all pathways, antimicrobial stewardship mandates rapid reassessment with culture and, where available, 6-hour rapid susceptibility data to enable early transition from empiric IV therapy to targeted oral agents. minimizing exposure, resistance selection pressure, and hospitalization duration while maintaining clinical efficacy. Hey, new drug, gepotidacin, is the first in class, oh boy, I'm going to murder all these names, triazoxanofillin antibiotic with a novel mechanism of action that inhibits bacterial DNA replication by targeting two distinct type 2 topoisomerase enzymes, DNA gyrase and topoisomerase 4, at a different binding site than fluoroquinolones, which helps preserve activity against many resistant uropathogens. It has shown strong clinical utility in uncomplicated urinary tract infections, particularly against common pathogens such as E. coli, including strains with resistance to standard first-line agents. In clinical trials, gepotidacin demonstrated non-inferiority to nitrofurantoin with a favorable safety profile, offering an oral treatment option that may help reduce reliance on fluoroquinolones and broaden stewardship-aligned choices for resistant infections. Ongoing evaluation focuses on resistant development, optimal stewardship positioning, and its potential role in future outpatient UTI algorithms. Here's another new one. Sublingual immunoprophylaxis with MV140 represents a novel, non-antibiotic preventative strategy for recurrent urinary tract infections, utilizing a polybacterial vaccine formulation designed to stimulate mucosal and systemic immune responses against common uropathogens such as E. coli, Klebsiella, Enterococcus, and Proteus. Administered orally under the tongue, MV140 aims to enhance innate and adaptive immunity at the urothelial level, reducing the frequency and severity of recurrent infections without contributing to antimicrobial resistance. Emerging clinical studies suggest a significant reduction in UTI recurrence rates and decreased antibiotic use in selected patients, particularly those with recurrent uncomplicated cystitis. While not universally incorporated into major guideline pathways, MV140 is gaining attention as part of a broader antimicrobial stewardship and preventative urology strategy, with ongoing research needed to define long-term efficacy, durability of response, and optimal patient selection criteria. Wow. Now a word about CAUTI, catheter-associated urinary tract infections. They remain one of the most common healthcare-associated infections and is largely preventable through strict adherence to catheter necessity, insertion techniques, and maintenance protocols. Risk increases with prolonged catheter dwell time, breaks in a closed drainage system, and improper perineal or catheter care, making early removal the most effective preventative strategy. Importantly, bacteriuria is nearly universal in long-term catheterization and does not alone indicate infection. Diagnosis of CAUTI requires compatible clinical signs such as a fever, suprapubic or flank pain, or systemic features of infection. Management should prioritize confirmation of true infection, replacement or removal of the catheter when indicated, and culture-directed antimicrobial therapy rather than empiric treatment of asymptomatic bacteriuria. A strong CAUTI prevention program integrates nurse-driven removal programs, daily catheter necessity review, and antimicrobial stewardship to reduce both infection rates and unnecessary antibiotic exposure. So, in summary, modern UTI care and healthcare practice is increasingly defined by precision, stewardship, and disciplined clinical verification rather than reflexive treatment of years ago. Across uncomplicated, complicated, catheter-associated, and typical presentations, the central principles remain consistent. Confirm infection before treating, stratify severity accurately, and match antimicrobial intensity to true risk while minimizing unnecessary exposure. Rapid diagnostics, structured pathways, and emerging preventative strategies are reshaping decision-making, but they must be anchored in clinical context and guideline-directed practice to avoid both overtreatment and missing serious infections. Ultimately, improving outcomes depends on integrated evidence-based medicine with thoughtful bedside assessment, ensuring that antibiotics are used deliberately, sparingly, and only when clearly indicated. So now we'll go to questions. Hey, Lori, welcome back. So, lot of stuff to unpack, and I thought I'd kick off with a question to the audience that's watching. What's your go-to antibiotic for what you would probably consider an uncomplicated UTI? And I'll start with you, Lori, and fans, you can put it into the comments.
It's definitely nitrofurantoin. But again, you do
Yeah.
have to be careful. We use a lot of Bactrim as well. But we got to be careful with Bactrim with people on, Coumadin and things like that. But the macrobid, if it's a healthy young person, that's a go-to. And I think now the treatment, we used to do 7-10 days, and now it's 3,
Shorter,
5.
yeah, definitely.
It's shorter. So that's what we use.
Yeah. And are you getting a culture on everybody ahead of time, or kind of treat then or culture then treat them right away?
Yeah, we usually culture them, but we wait for the results usually to start treatment, unless
Mhm.
they're severely symptomatic. Maybe some of our providers will go ahead and put them on an antibiotic if it's pretty obvious and they're miserable. But if they just have simple symptoms, we will wait until the culture comes back to make sure that we're putting them on appropriate treatment and not
Yeah.
just playing from. I mean, I remember the days that everybody was thrown an antibiotic without a culture. If they had symptoms, we would just put them on it. And now it's just more conservative just because of the resistances.
Yeah. And in all fairness, years ago you had to wait 3 days at least for a culture to come back. Now
Yeah.
we've got these more rapid tests that are coming back overnight. And then what I kind of talked to about in the thing with the slides I was going through is there's actually some that are 6 hours now that are going to be coming out. I don't think they're FDA
Wow.
approved yet, but they're just amazingly fast and with sensitivities, the way they're able to grow it. I'm a big
Wow.
Star Trek fan. That's kind of what I think about when I watch some of the stuff happening right now with AI
Yeah.
and all this stuff is it's getting closer to the practice of medicine that you see on Star Trek. Just
Right. It's
you
crazy.
run over that little scanner and oh, this guy has this and this is what I need to do to treat it. So
Right.
neat.
Right.
All right, and I'm not seeing anybody putting in any of their choices for antibiotics. So if you haven't had a chance, put them in the comments. We'll get them and we'll talk about them. Now I've been around for a while, obviously, and I can remember when the quinolones first hit the market.
Oh,
I mean, it was like the wonder drug that had just finally came to market, and they would come in and tell you that this is the first antibiotic that you're never going to see. And they said, never going to see resistance to. And I guess, I mean, we all know that never happened. Bacteria are smarter than we are. What can I say? But do you use quinolones much anymore?
you know what? It was funny because the other day was the first time in a really long time that I had a patient. He was extremely sick. He had gone to the hospital, he was hospitalized and so forth, and he was on Cipro. And I was like, wow, they actually put that person on Cipro. You just
Yeah.
don't see it anymore. I mean, we used to use it, we used to give a Cipro to every procedure. We used to do
Right.
prostate biopsies, cystos. It was all on hand. We any male who had prostatitis symptoms, they got 30 days of it over and over and over. And you just
They
don't see
gave
that
them out
anymore.
like breath mints.
Yep.
I
Yep.
mean, it was really crazy, but they were really good at marketing too. So I'm sure that's had something to do with it, especially Cipro.
Yeah.
When the first one came out, Neuroxin, it was marketed as the first new drug, and then the ciprofloxacin came out, and those guys they knew how to market.
hmm
It was
Did you
like
see a lot of the tendon rupture?
we saw some, not a lot. How about yourself?
Yeah, same here. I mean, there was a fair amount. Let's just put
Yeah.
it that way. Yeah.
More than you'd like more than I would want to ever take Cipro for.
Correct.
'Cause
Correct.
it's not a nice thing to see.
And patients were aware of it.
Yeah.
They would bring it up like, oh, well, I already have this issue. I don't want a chance having, a tendon rupture. And then we switch it.
Yeah.
But yeah.
And on the other hand, patients would come in saying, "Oh, don't give me that nitrofurantoin. I know the only thing that'll work is Cipro." So
Correct.
they were demanding it. So it's kind
For
of a
sure. Yep.
strange way. So we do have a couple comments coming in here. Fran, welcome to the show, Fran. Excellent presentation. There's so much controversy as what to do and when to do it. Can't argue that one. And then Janelle Finn, nitrofurantoin is their first choice in the office. That's funny. Now they're talk about a drug. Now that was right before I started practice when that one came in. But one of the urologists I worked with, who was about 10 years older than I am, was there as a med student when it first entered into the system. And he said it was like those reps were. He said, "You think Cipro reps were big? Those guys were even bigger."
Wow.
He said that was the miracle drug. Now, how about this new one, Blue Jeppa? Have you had any?
You know what? I've seen the name. I've seen the brochures. I don't think we have tried that one yet. It's probably not covered, is my guess. So
could be.
You know,
could be.
I don't know. I don't have experience with it and see what the coverage is on that. So
first new antibiotic to come out, it was let's see, 2025 is when it officially got passed. 1,500 milligrams twice a day for 5 days. Side effects: diarrhea, nausea, abdominal discomfort, flatulence, and headaches. Oh, that's always good. But again, one of those things, March of 2025, it was for treatment of uncomplicated urinary tract infections. First new class of oral antibiotics. And that's really the strange thing that happened, is this slowdown in any antibiotics coming to market.
Right. I guess the question is too, when they do the sensitivities, what does it fall under? I'm not sure.
Yeah, I'm not sure either.
Yeah.
One of the drawbacks of being retired and out of practice is you don't keep up with all the latest, except what I can read and research. I keep up with that way, but it's a lot of good questions. Anybody out there in the audience that's used it or heard of it, feel free to tell me. The other one I was really kind of surprised about, and I don't know if this one's out on market yet or still experimental, but where you take this dead bacteria and put it under your tongue. For urinary, it's an immuno response. I mean, it makes sense. I mean, we do things like BCG. You would never think that inoculating the bladder with tuberculosis would treat bladder cancer, but
so it's a preventative medication.
So it's a medication for urinary tract infection. Yeah. And they put it, you just put this under your tongue. And I was surprised when I read it in the literature, like, well, they're coming up with everything now. So it's good to know there's new things out there.
Interesting.
So I think urinary tract infections, the treatment of them has really changed. I mean, it used to be you treated everybody because it was probably easier just to give somebody a pill than have to go through all the trouble of trying to dig down to what's going on. But one of the big discoveries that I found in my career that surprised me is, number one, I was taught urine was sterile, and it's not.
Right.
Todd Thompson talked about that at one of our shows about the human microbiome, and that there's a lot of stuff that belongs in our urine. So sometimes sterilizing the urine or trying to sterilize it, not the best thing.
Yeah, I think the hardest part about the antibiotics are those who have been used to being treated all the time for whatever symptom, and now we're telling either the family member or the patient, you have cloudy, foul-smelling urine, but you don't have any other symptoms, we're not going to treat it. And those are the people that, can you do a urine culture at every cath change? And you're like, no, if you're not having symptoms, we're not doing a urine culture. And you try to explain it's probably going to come with bacteria, but we're not going to treat it if you're not having any symptoms. And that's the hardest thing for people to comprehend. They don't get it. Even just last week, I had a home health nurse call because of a patient having foul smelling urine. Well, does she have any other symptoms? No. And I think the other one that's really difficult are these elderly, that one of the signs of UTI in elderly could be confusion or fatigue. Right. And you get these people, these family members saying, oh, my mom, my dad, whatever, they're really tired and confused. I think they have a UTI. And it's hard because it could be just because they're elderly and they have confusion or fatigue. How do you determine what's appropriate? Yeah,
and that used to be the training back then is always watching the elderly for signs of some cognitive changes, because could just be a simple urinary tract infection. Well, now that's just not true. We need to dig deep, make sure that we're treating a urinary tract infection and not missing who knows, something else had happened.
Right.
So Fran Foley said, I've been retired for 2 years. Ever so grateful for the SUNA, I guess that's probably SUNA annual conference, so I can keep up on new meds. Janelle said, we still do 7-day treatments across the board. Interesting. You both say 3 to 5 at a urology office. Yep. Our providers say that many patients have recurrent UTIs, need longer treatment. What do you feel about that? So I'll let you start off with that. Do you think the 7-day treatment stands anymore?
I don't. We might give a longer course to somebody who might be a little bit older. Maybe their creatinine or their kidney function isn't the best. We'll do a longer treatment, but recurrent urinary tract infection patients, no, we still give the typical 3 to 5. I don't know if there's any studies out there that say putting them on longer antibiotics is better for somebody who has recurrent UTIs.
And the most recent AUA guidelines that I looked at did not encourage long-term antibiotics. The thought years ago was you wanted to wipe out all the bacteria, because if you left some behind, then it would just grow back. So that's why the long course of therapy was initiated.
We also, one of a couple of our providers had talked about UTI, and it used to be where somebody would take a course of antibiotics and say, I still have symptoms. Well, it's appropriate to retest them just to make sure things didn't change or what have you. But in most cases, they say after an infection, it could take 3 months for the mucosa to rebuild. And so symptoms are not uncommon for up to 3 months after you have an infection. So you have to be careful with, do you think that their UTI is not, it's not cleared yet. So they put them on more antibiotics. And that's
right.
Usually
they need
not
probably anti-inflammatories maybe instead.
Correct. Yeah.
Antibiotics. So, and that brings up a good point. One of the things that I also learned was that sometimes with especially our elderly female patients, the lack of estrogen is huge. These women are coming in seeing, multiple urologists for their recurrent urinary tract infections, and we started treating with estrogen, and suddenly they're not coming back for our urinary tract infections, and it was just an estrogen lack.
Definitely one of our big things when we see recurrent UTIs in, especially in, the females in menopausal age.
Yeah.
And it doesn't affect it doesn't matter if they have a history of breast cancer, family, whatever, that's all. We still put them on it. And it's amazing how you keep these people away.
The fear was always oral estrogens, and they didn't realize vaginal estrogen.
But vaginal estrogen cream is fine. Yeah.
Right. Just treat right at the source. So lots of interesting things that have changed. It's kind of fun to. That's why I always love urology. It's always interesting. Janelle said estrase is also first line defense. Thanks for mentioning. So bringing that one out there. So
I had asked one time. I had asked one time. I said, "Well, okay, so should you maybe have people in menopausal age or older using estrase even before you start to have the problem of recurrent UTIs, because it's good for other things?" And they said yes. A lot of people recommend estrogen cream for anyone in that age group, just to prevent future problems.
No, absolutely. It's often overlooked, and sometimes the simplest things are the ones that we miss. So it's been a great discussion. I think we certainly could go on and on about UTIs forever, because it's an interesting subject. That's why I decided to do a talk on it, because there's been some changes, some new drugs I noticed coming out to market, and I thought, well, this is a good time to revisit it. So it's always fun to kind of chat about that. Now, next week, we're going to come back to a subject that I haven't talked about in a long time, and I'm not going to talk about it, but I've got a guest speaker who does urodynamics, and she's going to be talking about urodynamics, and I think it's going to be fun to listen to see where we're at on that, because I haven't done urodynamics in years, so I'm sure there's some things that changed, but here's a little promo on that.
Learn how to properly set up and perform urodynamic testing in this comprehensive, step-by-step clinical guide designed for nurses, advanced practice providers, and urology professionals. In this episode of UroNurse, host Vic Senese is joined by urodynamic expert Vicky Clark to break down everything you need to know. Whether you're new to urodynamics or looking to refine your technique, this episode provides practical insights, real-world tips, and expert guidance to help you deliver safe, accurate, and patient-centered care. Join us on June 27th at 9 a.m. Central Time to learn more.
I look forward to seeing you all there. Don't miss it.
Gotta love AI. And I've never met Vicky Clark personally. We've just been going back and forth. I met her on LinkedIn and saw that she did urodynamics, and she's really excited to be on the show. So I'm sure it's going to be a great show just with her excitement that we've had so far going back and forth. So tune in for that. If you're not doing urodynamics, maybe you might start doing them. If you are doing them, I always find a tip or two that you can learn. So.
I'm telling you, I always love urodynamic talks. Love them.
Yeah, absolutely. And I think it's still a test that's really important. Sometimes taking somebody to surgery who's not going to benefit because their bladder's shot, best to know that beforehand so you could have that discussion with the patient rather than putting them through all this and then they're still no better. Patients don't like failure too much. They start losing their trust.
Right.
All right. Well, Lori, it's been great. We'll see you again next week, hopefully. Enjoy your summer between all the rain that we've been having. But you know what? I'm not complaining about the heat. We've had some of the best weather. Now,
yes,
I was in Florida, and on the cruise. Let me tell you, if you like Florida, great. You could have it because it's like 94 degrees. It was so hot. I went to get into the hot tub, which doesn't make sense, I know. But the floor was so hot, I almost like burned my feet just walking those couple of steps where I took my flip-flops off. It's just crazy. Not a problem outside here. It's been like in the 70s. I still haven't turned my air conditioning on. That's how nice it's been.
That's great.
So, got a nice cool breeze off the lake coming in all the time. So not complaining. All righty, everybody. We'll see everyone next week on UroNurse.